Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. An intensive care unit is a special unit in a hospital where patients who are very ill can be under constant supervision by their healthcare team. Indeed, this is where British Prime Minister Boris Johnson had been before he recovered. The COVID-19 pandemic has stressed the ICU and critical care units in hotspots where the virus has spread widely. Joining us to discuss critical medicine is Director of Critical Care Medicine at Mayo Clinic, Dr. Daniel Brown. Welcome to the program, Dr. Brown.
Thank you for having me.
First of all, how have you been? How have things changed in this COVID-19 pandemic era?
To be honest with you, they're pretty slow. We have been preparing the past several weeks for management of COVID-19 patients. And thankfully, the efforts that the country, state, and local individuals have been putting forth, the social distancing appear to be having favorable effects. And so the scenes that we've all unfortunately had the opportunity to witness remotely from New York and other parts of the world are not reaching us here in Rochester at the present time.
Well, that's wonderful news and uplifting news to hear. Can you explain to our listeners what would a patient typically be like if they're going into the ICU in terms of their medical status? Why would they need to be there?
COVID-19 presents like a viral pneumonia with various features of sepsis. So critically ill patients, predominantly with gas exchange abnormalities, prompting oxygen administration, and as this escalates, a patient may either present directly to the hospital and straight to the ICU or deteriorate on the floor and then require a higher level of care.
So when they're in a high level of care, are they all having machine breathing for them? Or are they awake during this? Are they asleep?
We're still using all of our modalities for respiratory support. So that includes everything from nasal cannula oxygen all the way up to mechanical ventilation and ECMO or extracorporeal membrane oxygenation. So the full gamut of respiratory support, much like we would see in other forms of viral pneumonia, complicated by the infectious possibilities associated with aerosol generating procedures.
If a patient is on a ventilator, how do you eventually bring them off the ventilator?
These patients are sedated to the degree that is required for them to tolerate mechanical ventilation. One of the concerns with lung injury is that the body is going to attempt to maintain appropriate oxygenation and ventilation. So a patient will breathe quite hard, and that can be actually injurious to the lungs. So we attempt to provide mechanical ventilatory assistance when needed, place a breathing tube, and then sedate the patient again to the degree that they are required to tolerate mechanical ventilation. Sometimes we actually have to pharmacologically paralyze patients such that they don't behave in a manner taking very large breaths that we know cause damage to the lungs. So this is all accompanied with, again, the appropriate level of sedation, and the staff that provide care to these patients are all well trained in this assessment and management of these patients. So we're well positioned, we're well trained, and patient outcomes thus far have been quite favorable.
When a patient is ventilated, on average, how long are they being ventilated for before they start breathing on their own?
This degree of respiratory illness is a bit longer in terms of mechanical ventilation than we typically often associated with the pneumonia. So these patients are intubated for days, more than a week at times. And as they begin to resolve their illness, they begin to breathe on their own, and we allow that. And when they're breathing sufficiently on their own and they have adequate oxygenation, the breathing tube comes out.
Now, it can be rather scary to be in the ICU. You know, the patient has been detached from their family. Can you tell us how the families are interacting with the patients? Are they allowed in the ICU? What's happening there?
The visitor policies have been severely restricted in an attempt to protect both staff and other patients. And so the only visitors that are presently allowed are for children or those individuals that a caregiver is intimate to their care outside of the hospital. And unfortunately, in situations where patients we do not think are going to recover and may well die, in those situations, we will allow visitors under tightly controlled situations to be at the bedside with the patient. We are using other forms of technology to communicate with patients. So, for example, in our medical ICU, we have tablets along with a program in touch. It's an application such that providers, family, etc., are able to interact with patients remotely. And again, it's facilitating care as well, such that the providers don't necessarily every time to communicate with a patient. They don't have to come into the room necessarily. They can do this remotely. And we're utilizing this and other technologies to facilitate that communication.
This is traumatic times. They're seeing disease that they may not have seen before. How are you finding the staff are holding up during this crisis?
Well, it's been a challenging situation in terms of the communications. There's so much that we are inundated with within Mayo communications and external communications as well. And I have to recognize and congratulate the staff and their ability to stay focused on what they're doing. They're incorporating these new changes into their workflows. Again, the numbers of patients have been small to date, and we are rotating other staff from parallel ICUs in to actually see what's involved in the care of these patients, but it is quite stressful. When we had Ebola, it was a very small group of providers that were trained for this and were prepared to take care of these patients. And the big difference now is that everybody needs to understand the challenges that are unique to caring for these patients, to keep not only our patients safe, but ourselves safe as well, and our families at home. So the staff, despite the trying situations, the trying circumstances we find ourselves both within healthcare and outside of healthcare, are really, to my way of looking at it, it's actually quite inspirational to see how people are weathering the storm.
Yeah, that's wonderful to hear. Now, you just mentioned obviously coming into work and then going home to your families. What are you doing to try and protect yourself and also your loved ones?
Listening to my family when I get home. So it's a parade of shedding the clothes at the door. I mean, I'm following the recommendations from our IPAC folks that indicate, that routine washing of our clothes is appropriate management for this. You see, I'm dressed right now a little bit more laid back than I normally am. Thankfully, I'm doing a fair amount of administrative time right now to be able to help our practice meet this challenge. But when you go out onto the floor, people have different approaches that they're using to balance their outside work. And thankfully, there's been a lot of education and information provided by our IPAC folks to deal with these questions. But practicing the same things we're practicing in here, the social distancing, et cetera, really are, again, to my way of thinking, when you look at the progression of this disease, I think we are having favorable impact for all of these measures. And again, at this point right here, we are not having transmission to our healthcare staff. We have not seen that yet, so our measures are being effective at this point.
You mentioned that there's thankfully not many COVID-19 patients in the ICU. Are you still seeing the other type of patients that you wouldn't routinely see during this pandemic?
We still continue to have disease within the community. One of the unfortunate things we're seeing, though, is actually a delay in some patients coming for routine non-COVID related care. And one of the things that we have to get the message out, I know the folks in the ED are doing this, and we'll start to hear this coming from hospital leadership and institutional leadership as well. But ongoing disease still exists within the community. People need to get care. They can come here and receive care in a safe manner. And that's one of the things we have to be cautioning the public about right now.
Patients still have disease and they still need to be taken care of. So I think that's a wonderful point that you make. Dan, anything else we need to talk about that we haven't so far?
No, I think we're prepared for this now. We're prepared going into the future. This is something we're going to have to manage, and we're going to have to adapt to it. We know how to do this safely, and thankfully, we're in the best place in the world to deal with this.
Absolutely. Our thanks to the Director of Critical Care Medicine at Mayo Clinic, Dr. Daniel Brown. Thank you very much.
Thank you kindly.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.